Ladies and gentlemen, I'm going to have you take your seats so we can start our final panel, please. So thanks so much for your patience. I know the day has been long, but we've got a lot of great panelists. We've had them before, and we have our 3 final panelists for our afternoon session. So in the interest of time, because we have run over, I'm going to actually ask that you hold your questions for our reception afterwards. Our panelists are aware of this, and they're more than happy to talk to you offline with any questions or comments that you have. So we want to make sure that they have the full time for their presentations. So our final panel for today is challenging multiple myeloma, breast, and cervical cancers in biodiverse communities. And we've got 3 very dynamic and very unique panelists who are going to speak to us this afternoon. On my left is Dr. Edith Mitchell. Dr. Mitchell is a clinical professor of medicine and medical oncology and program leader in gastrointestinal oncology at Thomas Jefferson University. She additionally holds the position of Associate Director of Diversity Programs for the Kimmel Cancer Center at Jefferson. Next to her is Ms. Deanna Darlington. Deanna is a Senior Director of Government Affairs for Onyx Pharmaceuticals. She directs federal and state legislative and government affairs activities and provides recommendations and implements strategies that respond to government's actions that affect business initiatives and strategy. And finally, to her left, is Chris Draft. So Chris is a former NFL linebacker, and when he's not playing, or now that he's retired, he is a community activist and founder of the Chris Draft Family Foundation. And his mission in life is focused on striving to make a positive difference in the lives of youth and in the community as he leads by example both on and off the field. So welcome to our panelists, and we're actually going to start with a presentation by Dr. Mitchell.
What advances per slide? This. Thank you very much, and thanks to the other panelists for our sharing this opportunity to work together. And Audra, thanks for that lovely introduction. I appreciate it. So thanks to everybody for staying with us. And what I'm going to talk about, Dr. Puckrin had asked me to talk about breast cancer in African Americans, and I selected the topic of triple-negative breast cancer. So join with me in our discussion of triple-negative breast cancer. I have no relevant disclosures. And I want to start with a case because this is a very typical case of a patient with triple-negative breast cancer. 43 years old, premenopausal African-American woman with a strong family history of breast cancer and a confirmed BRCA1 mutation. Diagnosis, she had felt the mass in her breast herself. When she came in to see me, she said, I had a normal mammogram about 3 months ago. She was diagnosed with a T2N1, so there were lymph nodes involved, invasive ductal carcinoma. She underwent surgery and radiation. It was a high-grade tumor, very poorly differentiated, 2.5 centimeters. ER/PR negative and HER2 negative. Ki67, which is a proliferative index, was high, and there were 3 of 20 positive lymph nodes. So she underwent standard treatment, chemotherapy, followed by radiation, and then about 2.5 years later, developed recurrent disease. And her recurrent disease, she had had a 1-month evaluation prior to that was negative, and she presented with widespread disease, weight loss, appetite loss, etc. Liver metastases and spine metastases, and she was not doing well. She had no other medical problems. So this is a typical patient with triple-negative breast cancer, and I will show you later how it rapidly grows. Unfortunately, we're told that in 2015, there are going to be 1.5 million new cancer cases, and unfortunately, nearly 600,000 individuals in this country will lose their lives to cancer. But there has been a 20% decline in death rates over the last 2 decades. So for women, note that breast cancer is the leading cause of cancer, yet lung and bronchus accounts for the leading deaths in cancer. So breast cancer, the #1 cancer in terms of incidence in women. And from 1930 to 2011, note the pink line, that breast cancer overall death rates are declining significantly. So we're doing better. Yet, however, if one looks at individuals, and if you divide patients into white or black, and that's how they have been classified over the years, for African American patients, whether they present with localized breast cancer, cancer that spread to lymph nodes, or have distant metastases at the time of diagnosis, African American patients do worse. So even though presenting with early disease. Yet when we look at trends from 1975 to 2002, note that Caucasian patients had better overall survival, and yet for African Americans, that survival in 2002 was about the same as for Caucasian patients 20 years earlier. So poor survival. And, oops, I think that went backwards. So what are some of the findings? Well, breast imaging has improved significantly. Not only do we have the mammogram, but we have PET scans, MRIs, ultrasounds, and others that we use. And mammography is the standard because it detects early lesions, and mammography has actually reduced breast cancer death rates by nearly 50%. So it is the standard. However, for African American women, there is a higher incidence of dense breast. And by dense breast, I will show you a picture. We find that it can obscure the cancers on mammography, and consequently, we may have to use other modalities to evaluate the patients. Pennsylvania has established a law that physicians must inform their patients of dense breast, and several other states have likewise legislation. But for dense breast, we find that there's decreased mammography sensitivity, a higher incidence of cancers, and the increased risk of breast cancer may be 4 to 6 times as high. And this is what we mean. On your left is a normal mammogram, and note that you can even see the blood vessels in the breast. Whereas the breast on the right is dense, there's more fibrous or stroma and more fibrous tissue, and that can obscure blood vessels, small lesions, small tumors. Consequently, we may have to resort to other modalities for imaging in these patients. So prognostic findings, there's HER2, there's also the estrogen and progesterone receptors, and they can help us in terms of not only prognosis of the patient, but also in determining treatment. So what do we mean by triple negative breast cancer? There's no expression of either estrogen receptors, progesterone receptors, or B2 or HER2 receptors. It accounts for 15% of breast cancers in the United States, but in some areas it accounts for nearly 40% of breast cancers in African Americans. These tumors are aggressive, and just as in the patient I presented, the tumors are advanced at diagnosis. They tend to recur earlier and tend to recur in major organs. They're more commonly seen in young women, African Americans, Latino and Hispanic women, and 80% have BRCA mutations. The timing of recurrence in triple-negative breast cancer is very important. The majority of recurrences occurring within 2 to 3 years of treatment, whereas for non-triple-negative, these tumors tend to have a longer time period and therefore may recur much later. Gene expression panels are very clear, and if you look at the molecular profiles of the tumor and note overall survival on the right side, note that the E, the pink one, these are the triple-negative tumors, and they have less survival. The survival rate is lower. So this is a database of Joint Commission hospitals, and I'll show you 1 year of breast cancer evaluation in these hospitals, more than 1,600 hospitals throughout the country. And note that if patients are divided into white or African American, note that for age, 22% of breast cancers in young are in African Americans that occur in young women less than age 45. So young women with breast cancer, if one looks at stage 0 and stage 1 have a much higher incidence of Caucasian patients, and note that nearly 60% of Caucasian patients have stage 0 or 1 tumors, whereas those in yellow for African Americans, a much higher number of stage 2, 3, and 4, which are more advanced tumors. So more advanced tumors. For histopathologic features, well-differentiated tumors have a much better prognosis than poorly differentiated tumors, and consequently, African American women have a much higher incidence of these poorly differentiated tumors. If one looks at estrogen receptor negative tumors have a much higher proliferative rate. They metastasize earlier. And note that for women less than age 45, 52% of African American patients have these estrogen receptor negative tumors that are rapidly proliferative. If we stage according to the various stages of 1 through 4, note that for African Americans, whether they present with early stage disease or late stage disease, the estrogen receptor negative tumors are the more predominant feature. And then for income, it has been touted that this is a disease of poor women, but note in this study that included 70% of all hospitals in this country, whether one had an income of less than $30,000 or greater than $46,000, there is a predominance of triple-negative breast cancers in African American women in these income groups. So, younger age, more advanced stage at the time of presentation, more biologically aggressive tumors, and these findings are consistent across all areas, age, stage, and income. So, therefore, again, another study showing these tumors more prominent in African American patients. And this is just the classic presentation that summarizes the fact that the tumors occur in the brain, the liver, the lungs, and other major organs much faster, and fewer tumors metastasizing to bone. We are looking at molecular subtypes in the tumors now, and it's very clear that you can separate breast cancers into these various categories. And from the Carolina study, they looked at these receptors in patients, and similar data, African American women having more of the aggressive tumors, lymph node involvement at the time of diagnosis, and fewer of the well-differentiated tumors. And this is just a summary of their studies showing that basal-like significantly more common in young women less than 50 and in African Americans. So BRCA1, I mentioned that 80% of these tumors have mutations. Therefore, the typical chemotherapy agents that we've used for breast cancer treatment are not effective. And we have used mainly the platinums, which are used for lung cancer and a number of others, but have not shown significant benefit overall in breast cancer, but we find that they are more sensitive to the triple negative and the BRCA tumor. So we are using different chemotherapy agents. We have more testing, more molecular testing, and therefore, if we confirm that there is triple negative breast cancer, it is my recommendation to go on with the genetic testing because there are a number of clinical trials ongoing in relationship to this. This is our team at Jefferson, and we have a large team that is working on triple negative breast cancer to try and find these other agents that might be of benefit. One of the agents that we are working with is a PARP inhibitor. Chemotherapy and radiation damage DNA, but these tumors have the ability to repair that. So using a repair inhibitor, we think has benefit, and these trials are ongoing. We simply do a lot of molecular testing and use the PARP inhibitor in treatment. So this is a typical treatment plan where we use the PARP inhibitor, the chemotherapy, to see if the PARP inhibitor actually prevents the repair that repair to the damage that DNA that chemotherapy and radiation cause. So these are studies that are ongoing, biomarkers and so forth. Another area, inflammatory breast cancer, where there is total infiltration of the skin with breast cancer cells, and there is an inflammatory reaction with swelling, edema, and erythema, and the cancer cells actually invading the skin. So in conclusion, what we can say about the disparities in breast cancer in this country, that triple negative breast cancer is one of the contributing factors to disparities. It is very important that we understand triple negative breast cancer, that we involve women with early mammography, early testing, and if there are dense breasts, a consultation is needed to see if other imaging modalities may offer benefit. So triple negative breast cancer, it's not homogeneous, but we have to study it and look at the molecular profiles. There is no specific target that we have at this time, so research to try and define targets, very important. It represents a much unmet medical need. It is something that should be on our radar screen and on our research priorities. And research strategies focusing on DNA replication, molecular aspects of repair, and DNA damage, very important because it's so needed for our young women who present with breast cancer. So with that, I thank you, and I will be around for questions. My email is included. Thank you.
Thank you, Dr. Mitchell, and thank you all for hanging in there with us and staying with us to the end this evening. I recognize I'm the last panel between you and your evening, so we'll try to get through this as quickly as possible. So my name is Deanna Darlington, and I am with Amgen's Government Affairs Office as well as Onyx. We've recently integrated into one organization. I work in the Washington, D.C. office. My key stakeholders are our patients here in Washington, D.C. with the policy arm. So my presentation will focus on that. We'll focus on how Amgen approach advocacy groups with the policy arm, but also I think it's important to speak to the broader organization organization within Washington, D.C., and how we work as a team and a group to work with our advocates. We also work with our federal lobbyists, we work with our payer representatives in the Washington, D.C. office, and we work with our colleagues back in Thousand Oaks and South San Francisco to ensure that all of our patient relationships are addressed appropriately and that we've provided attention to the needs of our patients. So with that, I'll start. Okay, a great leader once told me that if we put the patient in the center of our work, everything else will follow. And that's what we're trying to do at Amgen. We sincerely believe that as long as we focus our efforts on the patient, everything else that the patient needs, whether it's innovation, access, all of that will come along, and the patient needs will be addressed, and that's really what we're here for. So in order to do that, we believe that communication is key. And I think that we're evolving as an organization as to how we work with our patients, how they work with us. I think that we may have had moments when we may have had one-sided relationships or discussions, and I think that we're really trying to broaden that scope and have a two-way conversation with our patients, really understand what their policy priorities are, what their needs are, and what they're trying to accomplish with their goals. And we'd also like to have that conversation with our patients as well, recognizing that we have innovation and access as key policy priorities and issues for us, and I think that there's great opportunity for us to partner with our policy stakeholders here in Washington, D.C., primarily our patient audience. We also believe that by having that policy discussion with our patients, with our priorities, that's what really allows us to partner with them. And how we partner with them, I think, is what sort of sets us apart, in that it's no longer just okay, I support this program. I think that what we're trying to do now is saying, what do you want to get out of this? What is your message and your voice as a patient, and how can we support that? And vice versa. How do we want to show policies or support for policies that represent innovation and access, and how can we partner and create a platform for both organizations? So we'd really like to move forward and continue that approach and that voice with our patients. And finally, we'd like to take the approach of engaging our community, working with our community hospitals, working with our community doctors, working with our community groups, and educating them on various disease states and policy issues that may be important that they may not even realize that are important to them, but bringing that to their attention, but also learning and hearing their needs at a community level. So this is an area that we're really trying to move forward into at Amgen, and I'll give you a few examples as we go through the remainder of the presentation. Okay, so I pretty much summed this portion of the presentation up, in that I think our key takeaway, and one area I'd like to focus on, is the importance of disease education and awareness. I think that, you know, when we're on the Hill or when we're working with our various advocates, there's no greater need than to really understand what the disease is. How do we understand what this patient is going through, or a broad number of patients? What are they experiencing? So we really try to provide education, and I think that supports our needs from an industry, but also the needs of the patient, and helping policymakers understand their disease and educating them on areas that they may not know of. So that's really the first step in our relationship. And once we get to that disease education, then we focus on our policy priorities, our patient priorities as well as ours as an industry, and then moving that to the engagement and expanding that education at a much broader level to the community. And convening that community with stakeholders across Washington, bringing in our advocates, bringing in groups like National Minority Quality Forum, bringing in industry, and bringing in policymakers, so that we can really have a platform, and a diverse platform, that conveys each one of those stakeholders' priorities. And that is what I believe really constitutes a partnership, where we're working together and across diverse groups to have a common goal and to really make a difference from a policy arena. Okay, as I mentioned, I would go walk through some of the examples of that circle that was on that last slide. I'd just like to now just walk through some of the programs that we partnered with and truly partnered and understand what our patients' goals were and what our goals are as an industry, and sort of walk through what that looks like to Amgen. From a disease education awareness, I'm here to speak to multiple myeloma, and multiple myeloma, there is a health equity. There's 50% higher incidence of multiple myeloma amongst African Americans than that of white Americans. So we thought it was very important, not just from a health equity standpoint to convey that, but also as a disease to really communicate and educate on the disease to, again, our policymakers here, and bring our patients along with us to help our policymakers understand their experience as a patient. One area in which we've done that has been with working with local patient advocacy groups here in Washington, D.C. From a policy level. And one of those groups has been LLS, where we were able to develop and create patient videos to really understand the experience of that patient. Again, putting that patient in the middle and allowing the patient to educate the policymaker on their disease. We felt that that's really important. Also from a policy standpoint, and it's most specifically innovation, we thought it was very important for us to support those patients that are diagnosed with rare and orphan disease. Multiple myeloma happens to be a rare and orphan disease. So we work very closely with those groups as well, really underscoring the importance of innovation in these rare diseases, but again, also bringing that patient experience and creating and developing a platform for those patients to have a voice on the need for research and resources to really understand and treat those rare and orphan diseases, but also bringing in policymakers from the various governmental functions, whether it's FDA, whether it's NIH, whether it's policymakers on the Hill, really bringing them and engaging them into that conversation and dialogue. And that's an area that we've worked very closely with our patient advocates to do, but also to help our advocates create that platform. Very often, since I work very closely with members, my colleagues in the Washington office, we often do work with our patient advocates to develop congressional briefings, and where we're, again, providing education on the disease. When you look at multiple myeloma, it's really fascinating from the perspective of it's not just a disease where there's a higher incidence amongst African Americans and where there's a health disparity where that exists, but also, when you dig a little deeper, there's a lot of research out there around 9/11 and some of the exposure to those survivors and how there's a higher incidence of multiple myeloma within those 9/11 survivors. So we thought it was important to bring that message to the Hill regarding multiple myeloma. Also, we thought that it was important to continue to advocate for biomedical research. Again, as I mentioned earlier, innovation is key to our organization, is key as a policy priority for us as well as for our patient advocates. So we take policy briefings very seriously, and we try to do at least 5 or 6 of those a year. Also, in addition to the health equity that exists within multiple myeloma, there's other products and diseases that we focus on at Amgen as well as at Onyx. We look at liver cancer, where we know there's a higher incidence amongst Asian Americans. We also have disease or products that treat diseases like ALL, where there's a higher incidence of Latina women. So we really felt it was important for us to do something at least annually to really look at health equities and really bring thought leaders and patients together in one forum that could really provide education, but also try to look at challenges and identify solutions. At our most recent Health Equity Summit, I thought what I was most proud of was the fact that we brought in researchers that were able to really show the work that they're doing right now that are minimizing and reducing our health health equities. So that's an area that we're very proud of and that we will continue to do on an annual basis, and that we have partnered with National Minority Quality Forum to support that effort on. Another member of Congress that we've worked really closely with and done a number of events around multiple myeloma has been Congressman Clyburn. He has a very close relationship with multiple myeloma, very interested, feel the need for education to occur within that disease state. So we've not only engaged him in our health equity program, but we've also worked with him with South Carolina University to support or to educate around multiple myeloma and recognition of an annual meeting, health disparities meeting that is that the university hosts in his honor each year. So we've done quite a bit with him in the area of multiple myeloma, and again, that comes from not only just educating, but convening the community as well and working with individuals within his local area. We've done quite a few as well health fairs where we've worked with members of Congress within their territory with their region and actually focused on health fairs that were specific to multiple myeloma for a number of diseases, liver cancer and the ACA implementation. So we really try to engage members and policymakers within their community and their districts to help educate their constituents. And that's an area that we continue to plan on doing and working with policymakers that are passionate about various disease states, primarily cancer. I think we talked about this lecture series that we did with University of South Carolina. We had a panel. The panel was very diverse. We brought in a patient, we brought in a physician, we brought in local community groups, we had a speaker from Onyx, a physician, and they really had an excellent dialogue, not only with the students that were participating in this event, but I think we had a large presence from the community as a whole, and were really able to educate on the health inequities that were prevalent in multiple myeloma, but just more broadly from a health inequity standpoint. Oh, and let me just go back one more slide and speak to a very exciting program that we're doing at a community level around cancer in general. We're working with the local WETA station a lot, as well as the National Medical Association, NMA, to host a screening for the Emperor of all maladies, really to educate on cancer, to bring the community in, bring in a number of groups, make this very diverse, open this up to our policymakers, our patient advocates, as well as the community at large, and for the only purpose of education from a cancer perspective. So we're really proud of this event, and we hope that we'll be able to do many more of these in the future. Unfortunately, I'm not able to make this go forward, but I think that in the interest of time, my time is running out anyway. I think that what we can do is speak to one last area in which we work very hard with our trade associations to convene a broader organization, and that's with the BIOS and the various large congresses that occur across the country each year. We work to bring our patients and make them a part of that community, make them a part of that meeting, recognizing that oftentimes it's a very scientific message. We try to open up that meeting and bring in patients to understand what their concerns are in a very sort of separate environment. We will bring in a number of patient groups and just really understand what's on their mind, what is of interest to them at this particular meeting, and how can we support them in that effort. So again, constantly keeping that line of communication open, and I'd like to thank you all for your time and for staying with us, as well as my panel. Thank you.
For as long as he can remember, Chris Draft has cherished what most of us take for granted, that next breath.
I mean, just gasping, pretty much that. looking for the air.
Fighting to breathe is a way of life for Draft, who played linebacker in the NFL for 12 seasons, despite debilitating asthma attacks that often sent him to the hospital.
I look at it as a blessing of sorts, though, is that it makes me have to wake up and really take that breath each day.
What would you do today if every breath mattered? What decisions would you make if tomorrow wasn't guaranteed? Chris Draft and Keisha Rutledge met in 2006 when he was playing for the Carolina Panthers. There was an immediate connection.
Chris described Keisha as a beautiful woman who, walks through a room, brings a ton of personality.
But life in the NFL for a journeyman linebacker isn't conducive to settling down. Draft bounced from Carolina to St. Louis, to Buffalo, to Washington, where his career ended in 2010. All the while, Keisha waited.
Was there ever a point at which she said, "What's the deal?"
There was a couple of times. There definitely was.
But what would you tell her?
So we're getting closer. No, she didn't like to hear that, but we're getting closer.
Finally, in 2010, Chris and Keisha were able to be together all the time. But suddenly Keisha, a fit 37-year-old, a former dancer with the Charlotte Hornets Honeybees, started having trouble breathing. Despite the fact that she'd never smoked, Keisha was diagnosed with stage 4 lung cancer. The average life expectancy in such cases is 8 months.
You say one day at a time. But really, we're gonna fight this. We're gonna fight this. We're gonna fight this.
In the face of late-stage cancer, Chris and Keisha's vision of their shared future might have melted away, but it didn't. In August 2011, 8 months after Keisha's initial diagnosis, with her condition worsening, Chris proposed.
You can't guarantee what's tomorrow. You can't do that. Just one more day, I'll take it. 2, I'll take that. But to have that with your wife, the woman that you love, take me some seconds. If that's, give me 60 more seconds.
By the time of the wedding, Keisha was mostly confined to a wheelchair. But on that day, nothing could diminish her happiness.
Gotta see the strength. So it's not like you see just your wife coming, but really seeing everything about her that makes her, just in that moment, everything that makes her my wife.
Oh, so long for this night I prayed that a star would guide you my way to share with me this special day where ribbons in the sky for our love.
Within a few weeks of the wedding, Keisha's organs were failing, and her pain was increasing.
We were blessed to be able to have, Christmas back here, and all the family came down, so she was able to talk to them. But, some battles you just don't win.
When Keisha died on December 27th, Chris was at her side. She was 38. They were married for only 5 weeks, far too briefly. But together, they had made every breath count.
It'll always be a great memory of seeing her walk down the aisle. That consistent fight. Just that each day that she's able to refocus. And to see that type of strength every day. Every day.
Thank you. It's a pleasure to be here, to be able to share. You guys got a chance to see my wife, got a chance to see her. lung cancer. Lung cancer. So in 2010, I was in training camp here with the Washington Redskins. I was released. I'm back at home, and I'm working out, and my girlfriend at that time, she's saying, "Why don't you do P90X with me and run a 10K?" And so it's important to know that that's the kind of shape that she was in. She's telling me, I know you're doing your workouts, but you need to do P90X with me, and you're going to run 6 miles. And as an NFL linebacker in his 13th year, that is the last thing that I want to do, is run 6 miles. But when you have an amazing woman like that, down in the South, you'll say, no ma'am, or no ma'am, and then after a little while, you just say, yes ma'am, which meant I was going to be running with her. But I say that because that's the shape. There was an amazing shape, and then we get here to December of 2010, and all of a sudden she has a little shortness of breath. A little shortness of breath. And she wasn't one that like some of us men, you got to wait till something to fall off. Something is hanging there, the leg is swinging or something like that before you go in and get checked out. That wasn't her. As soon as she found something out, if something felt wrong, she was in there. When she was a pharmaceutical sales, she had worked for Santa Fe Adventist, had a great relationship with her primary care doc. So when she went in right away. A little shortness of breath, and the primary care doc, because she had a great relationship with her primary care doc, he said, you know what, it's a little shortness of breath, but let's make sure we get a chest x-ray. And I say that because it's very important as looking at the diagnosis. We're talking about some of the health disparities and some of the things, unfortunately, with African Americans we haven't done great with in terms of, kind of access to care, but she made sure she was there. And then with that relationship with her primary care doc, got a chest x-ray. Now that's, unfortunately within lung cancer, there's so many people that go in and are misdiagnosed because the doctor won't give them a chest x-ray because they say, well, it's just not that bad. It's got to be something else. And, so one of the things that's crazy with lung cancer is that, when you think of breast cancer, you think of if there's anything that's kind of in this area, we're going to think that that's breast cancer, but lung cancer, the list is so vast of lung disease before you get to lung cancer, and then for her being 37 years old, you just don't think that. But a primary care doc had a good feel for her, made sure she had a chest x-ray. We found out in December that she had a mass in her left lung. Lung cancer. After a PET scan, he found out that it spread. Stage 4. Lung cancer. Now, for somebody that, you don't try to get to know about cancer unless you're in this profession. You don't really decide, I want to go out and find out all about cancer. So, understanding staging is real. You don't really realize how important that stage 1 and stage 2 are and versus stage 3 and stage 4 and how that means that things have spread and what spreading means and how spreading affects treatment until you get right in. Stage 4 lung cancer. You don't understand the differences between cancers. You don't understand survival rates in between cancers until you get down in it. About a month after my wife was diagnosed, a good friend of hers was diagnosed with Hodgkin's lymphoma. A month after that, one of her friends, his wife, was diagnosed with breast cancer. Both those ladies are still here. You don't understand those differences until we get down into this space. We don't understand how important it is to have people that you can communicate with. My wife, when she was diagnosed, she had a great group of people around her. You just could not ask for a better group. I was almost jealous. I was jealous and at the same time thankful. So thankful that one of her best friends actually worked directly with the lung specialists at Emory University in Atlanta and worked on clinical trials. That she had doctors, her friends, that they were calling all their friends that are doctors and oncologists, and we would walk out of a place, she would call one of them, we'd have second, third, fourth opinions before we even got home. Amazing. We were blessed to be at Emory. Where we had a doctor. His name was Dr. Scott Kono, who was actually trained at the University of Colorado. And in 2011, right at the beginning of 2011, when my wife was, basically when her diagnosis was secured, Targeted therapies, that's something that is new. We're talking about the importance of identifying these mutations with breast cancer. HER2 is a very common one. We saw that at 20 to 25% on Dr. Mitchell's presentation. Well, that was fairly new as it related to lung cancer. So she was tested for EGFR and ALK at that particular time, and those are mutations as it relates to lung cancer. But that was not completely standard across the academic community, let alone community hospitals. So we know that was big. Now, she came back negative for both of us, but as we see right now, as we move forward and see some of the people that are surviving, those are critical. The targeted therapies are critical in survivorship. But she was tested. She came back negative for that. And so what she did is came on standard chemotherapy. Standard chemotherapy again. I mean, until you get in this space, you just don't understand those words. Those things start rattling off now. So now you see cisplatin up there. You see Alimta. You see carboplatin. You see Taxol, paclitaxel. These types of things, these words that you just did not want to know. These are not things that you wanted in your toolbox, and all of a sudden you get a great vocabulary. Great vocabulary in that. So my wife ended up on carboplatin and Taxol as a first line therapy. Chemotherapy goes and just tears that body apart, and it worked. It worked, for as well as it could. But there's side effects. The side effects are hair loss, a little bit more fatigue. Transition off of those, and then there's maintenance drugs. Again, you find out these things as chemotherapy that you get a first-line therapy. First-line therapy, then there's maintenance therapies. Maintenance therapy was a Lilly drug that had done real well. It's Alimta. Now we were hoping, man, that we can get this drug. Unfortunately, it didn't work well for her. Did not work well for her. And again, I'm talking about a vocabulary as we're learning. We're learning as we go through this, learning the differences between lung cancer, the difference between other cancers, and then just understanding how serious this disease is. Well, that you guys saw with how the serious the disease is, and that is that my wife, in November, before we were married, she was actually able to get, she had to get radiation on her neck. And that radiation on her neck, based on new transformations within radiation, made it where if she hadn't got that surgery, got that radiation, that dose, she wouldn't have danced at our wedding. She would not have danced at our wedding. But she had to get that. She had to get that. At that same time, we found out that she had a HER2 mutation, which again is very common in breast cancer, but not so common in lung cancer. Those things are important. I'm saying those things because they're very important as we're telling the story of hope. My wife, unfortunately, after we were married, she passed away. It's about 5 weeks. December 27, 2011. But before that, on our wedding day, and before that wedding day, she made a commitment. The commitment was to the people, to anyone that's affected by lung cancer. So she came to me, she said, what if we ask our family and friends that are here to support the foundation? We don't need any presents. What if we fight against this disease? What do you think about that? I said, baby, I'm right on with that. And so we've committed, after she passed away, we've committed to that. We committed to a national campaign to change the face of lung cancer. As we've talked to the folks, and they said, well, what's the biggest thing that we have to know? And it really is that lung cancer is serious. That lung cancer kills more than breast and prostate and colon and pancreatic combined. Serious. Those are the next top 4. And lung cancer kills more than all of them. We got to know that it kills more than breast cancer. Breast cancer is the most diagnosed, but lung cancer kills more in women. Has since 1987. These facts. Serious. But we have to know why. Why does somebody care about that? Why would somebody care about these serious facts? And so somebody said there's a smoking stigma. There's this smoking stigma that's in the way, that's in the way, that's in the way. They said, well, we got to deal with that then. We got to deal with this smoking stigma. The smoking stigma really comes from not seeing people, only seeing just a prevention campaign. So when we looked at it, said, how do we make the biggest difference? Our biggest difference is going to be in making a case for why research would matter. And the only way that we can make a case for why research would matter is to show our survivors. Along with the fact, the only way that we can show that research would matter and then get the real support from the NFL, who I played in with 12 years, and my wife danced in the NBA, was to make it positive, to make it about the people. And so what we've done is we've committed to really get to know all the doctors at the cancer center. There's been over 130 of them, sat down with the lung cancer teams and really found out what's changing, what's hopeful. And in doing that, realized that the survivors really, they tell the story. They tell the story of what's changing. They tell the story of what's hopeful. But then the survivors also tell you why it matters. Why should it matter? So we've been able to use the spirit of my wife, that's a spirit of life, of living, and really infuse that within the lung cancer community and challenge them to say that people will not care about the numbers. Again, I tell you, the numbers are serious. They're absolutely serious. But people are not going to care about those numbers. Those numbers by themselves are bad, they're horrible, but it has got to be about people. So we have committed to changing the face of lung cancer, and changing the face of lung cancer, we're showing you people. If I had a little bit more time, I just didn't want to, I got a bunch of slides of folks, and I just do have limited time, otherwise I'll show you guys a whole bunch. You guys can go to our site and see a lot of them, but it is a bunch of people, a bunch of faces. What we committed to is making sure that we're going to show you this spectrum. We're going to show you diversity. We're going to show you what lung cancer looks like. And if you can see yourself in lung cancer, then you could care about it. But also the numbers are very sobering. So I said it kills more than breast, prostate, colon, and pancreatic. But then the 5-year survival rate is only 17%. Not good. And so we've got to give a nice little dose of hope with that. And that hope is real. A lot of changes are happening right now. A lot of changes that we're seeing in the number of survivors and how they're living. A lot of changes that you're going to see with those numbers in the future. But a lot of changes that you can't really see based on just the numbers. The numbers say that we measure cancer really in a 5-year survival rate. And I will tell you that my wife wouldn't even be at 5 years right now. So if we don't look at the people, if we don't measure it with the people, we might not see that. We've challenged the lung cancer community to really understand that, 1 year is amazing, 2 years are amazing. If we look at the moments that someone can have on our way to get to those 5 years, and on our way to changing what those numbers are, there's a lot of life. And if we don't appreciate all of those moments, then how can we keep moving forward? And how can we make sure that other people know that there's hope so they can continue to support it? We're committed to changing the face of lung cancer. We're committed to loving our survivors. We're committed to putting a group around them that is educated and so that they can be empowered as patients. And then reminding them and reminding the community that change is happening. The change is not just us changing what the survivors look like. They've already been there. The change is happening in our treatment. The change is happening in our early detection. Change is happening. You might not see it in the numbers if you don't look deep enough, but that change is happening, and it matters because it looks like us. Thank you.
Thank you so much, Chris, for sharing your story. And can we give a round of applause again for our panelists, Dr. Edith Mitchell, Deanna Darlington, and Chris Draft. And thank you so much for our afternoon panel session. And now we're going to be off to our reception. So.